Welcome, everyone, to this webinar tonight. My name is Dr. Ben Buchanan. I'm the co-founder of Novopsych, and really pleased to be hosting this webinar with Monique Mitchelson on neuroaffirming practices. Um, we've had an incredible response tonight to this webinar, and I think that that is really because psychologists, psychiatrists, anyone working in mental health realizes that getting across neuroaffirming principles, understanding autism and ADHD is absolutely critical to mental health work that they do. Over the years, Novopsych has been evolving our assessments, and we've been aligning our assessments more with neuroaffirming principles. We've tried to move away from deficit-focused language to create and celebrate strengths and diversity. And this transition in Novopsych is really a reflection of Novopsych's values, where we want to empower clinicians and also empower clients, and the fact that we believe that high quality assessments can have therapeutic value in and of themselves. And before I hand over to Monique, I'd like to draw your attention to a few assessments that we've got newly minted in Novopsych. Firstly, the Comprehensive Autistic Trait Inventory by Dr. Michael English, an Australian author, is absolutely fantastic. It has a number of different subscales: social interaction, social camouflaging, and we've tried to, in our reports on Novopsych, really make it easy to understand, where you can compare the respondent scores between people without autism and people with autism. And so we think that this is the best screening tool around, and it overcomes many of the issues with other assessments such as the AQ. For ADHD, something that we've recently updated is the ASRS. We've got this beautiful graph now showing where the respondent scores in comparison to norms. And so you can see that there's a community group and there's an ADHD group. And then you can see where your respondent scores to get a little bit more precision and understanding about the diversity of responses that people can have with ADHD. And another one that's a real favorite of ours is the Executive Skills Questionnaire, which is a really practical measure for ADHD, and also autism, which really identifies skills that someone can be working on in order to improve daily functioning, like time management, emotion regulation, and behavior regulation. So this evening, we're very lucky to be joined by Monique Mitchelson, a clinical psychologist and co-founder of Divergent Futures, who has been at the forefront of neurodiversity-affirming therapy in Australia for a few years now. Monique is also the co-host of the Neurodivergent Woman podcast, an Australian podcast with over 1.5 million downloads, combining lived experience with clinical expertise to educate and to also inspire. Her transformative work and advocacy make her an exceptional speaker for tonight's session. So, hey, Monique, welcome.
Hello. Thank you very much for having me come on with Novopsych and do this webinar.
So to kick off, I wonder if I can ask you a couple of questions. So how long have you been really passionate about neurodiversity affirming approaches in a clinical setting?
I would say that I first was exposed to the neurodiversity affirming approach and that practice in 2020, like around when COVID shut us all down. And I first got to read an amazing book that went through the history around autism, and yeah, went through and looked at the different movements. But yeah, I've been aware that there's been autistic family members, and my husband is also autistic and ADHD, as am I. And yeah, like I first realized that I was likely autistic back in 2017 when I attended a training by Tony Outward on autism in adults and women. And yeah, a lot of stuff resonated, and I thought, wow, how come I haven't learned any of this yet? I'm a clinical psychologist working at a practice, that works a lot with autism and ADHD, but I mainly work with adults. So
Right.
yeah, it's very eye-opening.
It is amazing, isn't it, that and that self-knowledge. And I wonder, with that self-knowledge that you've gained over the last few years, how has that informed the way you work clinically?
Yeah, it's being extremely important. I would say that through going through my own learning about autism and ADHD and through my own experiences, being able to it's given me a deep understanding of what a lot of autistic and ADHD, what a lot of people's experiences are. And I think having that combination of lived experience with the clinical skills has been really helpful for working with clients. Yeah.
Oh, fantastic. So I'm going to leave it to you now.
Awesome. Let's get started. We've got a lot to get through. So thank you everyone so much for coming to the webinar tonight. Ben has kindly introduced me, and we are going to be looking at identifying autism and ADHD in adults, a neurodiversity affirming approach in clinical practice. First, before we begin, I just want to acknowledge country. So I live and work on Quandamooka country. So just wanting to pay my respects to elders past, present, and emerging, because they hold the memories, traditions, cultures, and hopes of their people. And yeah, I just want to acknowledge the privilege of being able to live on this land. And yeah, it's really beautiful. Okay, so I am co-director of Divergent Futures. My other co-director, Anna Clark, is a psychologist and play therapist who mainly works with children and teenagers. And we started Divergent Futures a couple of years ago, really aiming to provide training that is neurodiversity affirming, because we believe that difference doesn't need to be fixed, but it's to be embraced, and that neurodivergent people have the right to feel safe being their true selves without facing stigma and discrimination in society. And understanding, recognizing, and supporting neurodivergence is really integral when working in the mental health field. So quick spruik as well. So I'm co-author of this book. So if you want to learn more about neurodiversity affirming therapy, yeah, it's a very practical book that looks at all the skills that you may need as a therapist or as a person who's autistic and ADHD, people working in this population, parents, carers, teachers. Yeah, it's got lots of practical skills and worksheets in there. Okay, so let's get into it. So neurodiversity has become a massive buzzword in the past few years, particularly since COVID, and there has been a real surge of people getting diagnoses often as adults, may have been missed out as being identified as autistic or ADHD in childhood. And yeah, there's been a lot more articles, things in the media, things on the news, TV shows talking about autism and ADHD and providing lots of examples of different types of people who are autistic and ADHD. So there's been a big driver of conversation. But what actually is the concept of neurodiversity? So the concept of neurodiversity really refers to the neurocognitive variation that occurs naturally in the human species, so that everyone has a unique and different neurology. And it comes from the concept of biodiversity, which looks at the fact that natural variation exists within different environments, and we really need all different types of, plants, animals, flora, fauna, like bacteria, everything, variation in the environment for the conservation of the environment and the conservation of the species. So yeah, it really highlights that being different, being a neurominority, maybe not falling within that neuromajority isn't necessarily being disordered or wrong. And that actually every human being, regardless of their neurotype or their neurology, has different sets of strengths and areas that they may find challenging, a different combination of abilities and needs as well. And it's really a term that came about from the autistic advocate community, particularly with the rise of the internet, people getting together and meeting, their community on the internet in the 2000s. And yeah, it came from a lot of advocacy around wanting to be accepted for being different and having a different type of brain rather than being cured or fixed. So when we're looking at the language around neurodiversity, there's different ways to use this language. So technically, we are all neurodiverse because we all form part of that spectrum of neurodiversity, just like we're all part of biodiversity when we look at the environment. So people who fall within the most common or average brain neurology began to be referred to as neurotypical or neurologically typical within the autistic community. So that's where, if you're in that neuro majority, you'll be referred to as NT or neurologically typical. Autistic people may also refer to neurotypical people as allistic as well. So that's part of that language. Autistic advocates began to refer to themselves as being neurodivergent or diverging from the norm or the majority. And it's a way of acknowledging underlying differences of neurocognition in a more empowering way. So as the movement has spread, the term neurodivergence now refers to people with a range of neurological differences, and it's not limited to autism and ADHD. It's also things like anything that's neurodevelopmental, anything that's genetic, brain-based, neurological, such as the learning differences like dyslexia, dyscalculia, movement and coordination differences like dyspraxia. OCD in some circles is considered to be a form of neurodivergence, as is tics and Tourette's. And then other biologically based differences like bipolar and schizophrenia. And there is ongoing debate within the neurodivergent community and outside of the neurodivergent community as well about things like acquired neurodivergence, such as complex trauma, because we know trauma changes the brain, as well as other things. So it's an ongoing development. So when we're looking at neurodiversity affirming practice, really the principles of neurodiversity affirming practice are basically, it's an approach including policies and attitudes that embraces diversity and embraces differences, rather than seeing these differences as pathology, something that's wrong, disordered, pathological, and needs to be fixed. And it's about understanding what the person's individual strengths and needs are and making changes and accommodations to their environment in a way that helps support what their needs and challenges are. So this is an approach that comes from a place of respect, so respecting all different types of brains, equity, wanting to work on changing environments so that they work for everybody rather than just the neurological majority, acceptance of difference, seeking to understand others and supporting others who are different. And so when we're looking at becoming neurodiversity affirming and bringing that into our practice, it's actually a process of ongoing reflection and unlearning some of the things that we have been taught in our training, as well as ongoing learning and professional development and keeping up to date with the advances in our understanding of autism and ADHD and our understanding from a more affirming perspective. And so often it's making adaptations to what you're already doing to accommodate. And sometimes it means taking a step back and thinking about your approach and thinking, is it affirming as well? One of the other things to think about as well with autism and ADHD is the idea that people who are neurologically different, so particularly with autism, with autistic people, we actually have our own cultural and social norms. There are autistic social norms. We have our own way of socializing. We have our own way of like preferring to communicate with people. And so it's almost taking a bit of a cultural difference approach rather than, again, going, okay, this person doesn't fit in with neurotypical social norms or communication styles. We need to train them to become neurotypical or appear neurotypical. And this brings me to a really important differentiator because, again, in mental health, and I can't speak for other disciplines, but I know within psychology, we're really focused on mental health. And if you go and work in the field of disability, it's actually a completely different paradigm. And often when working with mental health, the aim is to identify a person's symptoms, apply a treatment plan, and get an improvement in the person's mental health, their mood, their anxiety, their symptoms, and then try to prevent relapse. Whereas disability is a different ballgame, and it's really important to get your head around the fact that if you're working with autism and ADHD, which you absolutely are, even if you're not aware of it in your practice, then yeah, the way that you would approach it with mental health is different to how you would approach working with someone that has a neurodevelopmental difference or disability that is lifelong. It's not episodic. It is over the person's lifetime, and they may need support across their lifetime. Support more in some ways at some times and less support at other times, but yeah, ongoing support. And so it's important when we're looking at the history of psychology and mental health in general to really understand the history of disability, particularly in Australia. So I'm going to speak to Australia. I know we have lots of international people, but go and look up, when did disabled people actually first get rights in your country that you're living and working in, or your country of origin? Has your country actually signed on to the United Nations Convention on the Rights of Persons with Disabilities? Because there are nations out there that you think would have signed on that actually haven't. Because it wasn't until actually the 1980s that countries like Australia started to embrace the advocacy that had been happening for rights for people with disabilities. So up until the 80s and often, further along, if you were diagnosed as autistic, that could be extremely dangerous in terms of you may be institutionalized if you act differently or don't adhere to social norms and you have that label. So it wasn't until 2006 in Australia that that the United Nations actually came to an agreement on what are the rights of peoples with disabilities. And it was the first human rights treaty in the 21st century to protect and enhance the rights and opportunities of the world's estimated 650 million disabled people. And Australia signed on in 2008. So it wasn't until, that period of time that we signed on to the UN Convention that people with disabilities have an equal right to access education. They have an equal right to access employment, to participate in a cultural life, to go out and be part of the community, the right to own and inherit property, to not be discriminated against in marriage, and to not be the unwilling subjects in medical experiments. And it was because we signed on to this that led to the creation of the NDIS, in recognition of this, that it was the NDIS that initially said, come on, let's try and get adequate funding and support for people with disabilities to access these things. And the thing is that disabled people are actually one of the biggest minority groups in Australia. 1 out of 6 Australians have a disability. And not everyone who's autistic and ADHD may identify with the term disability or having a disability, but I personally do. And I proudly advocate that. And disability means that, things are harder for you. Things take longer. They take more time. They take more energy. They cost you more to be able to do things in the same way as other people. So I think it's important to have conversations about this when we dig into what is being neurodiversity affirming, and to look at the history and why, autistic and ADHD people maybe haven't had access to a lot of support and treatment. Another thing to be mindful of when we're deconstructing the model of the different models when working with disability is really thinking about what is the model that you were trained in, because a lot of psychology and psychiatry is based on the medical model, which is the most prevalent model in the Western world when it comes to health and mental health. When you're working with people from the medical model, though, disability is actually seen in terms of an impairment. And it's an impairment of the individual, the fault of an individual. So there's something wrong with you. You're not functioning like a typical person. And a lot of pathologizing language is used, such as abnormality, disorder, dysfunction. And because disability is seen as a problem of the individual, there's then experts that come around to do interventions with that person to try to return them to a normal level of functioning or be as least disabled as possible. And yeah, I think it's important to understand that a lot of psychology and psychological therapies, including, applied behavioral analysis in the past, have lent more towards this, particularly with disability. And unfortunately, the medical model can really feed into a morality model around disability. Like if you're disabled, there's something wrong with you and that's your fault. Or if you can't do things in the same way as other people, you're not trying hard enough. It also can feed into tragedy models. So people, rather than acceptance and support, feeling pity for people as well. And unfortunately, the medical model has led to the institutionalization and segregation of autistic and ADHD people in the past. For me to be able to come out and be openly an autistic clinical psychologist in Australia is a relatively new thing. And I have a lot of privilege that buffers me, that allows me to do that. So yeah, it's important to acknowledge that. Secondly, there's the economic model that looks at disability and things like autism and ADHD. And we think about this with maybe the levels of autism, which I'll speak about later, in terms of how much does this impairment affect your ability to work and pay taxes and contribute back to the state. So this is a more capitalist model. And yeah, unfortunately, there's negative consequences of that model. And then thirdly, we have the social model of disability. So a lot of the work around becoming neurodiversity affirming is reflecting on how you've been influenced by the other two models and really reflecting on how much of your practice is centered around the social model of disability. So in the social model of disability, disability is not seen as an attribute of the individual. So you may have, for example, a physical impairment, or you have cognitive impairment, cognitive difficulties. But in the social model of disability, it basically states that all of the environments and the systems around you have invisible barriers in them, and they're not actually designed for people with disabilities to have equity of access, and that adds on top of the barrier or impairment that you have. And that creates much more barriers to be able to participate in things and to be accepted and do things in a way that works for you rather than being, fixed. So in the social model of disability, it's looking at how do we change society, and that includes changing people's attitudes. That includes changing our systems, like our education system, our work and employment systems, to make them accessible for everybody. And yeah, equal access for people in this model is seen as a human rights issue. The social identity model takes it one step further and actually says that, you can identify as autistic and ADHD or as having a disability and actually claim that as a positive identity as well. So yeah, it's really different to the model that I think a lot of us were trained in. One other thing to keep in mind as well is when you're working with people, and often with people who are vulnerable and in vulnerable populations, often people have decisions made for them or things aren't properly explained, and informed consent isn't always clear. And so when we're working with autistic and ADHD people or people with disabilities, it's important to look at, are you working from the expert or professional model where you are the authority and you're placing an intervention upon a person to try and change them? Or are you working from the empowering model of disability, which is what the NDIS and things like that are supposed to be? So it's you as having expert knowledge and your clinical expertise, actually, offering guidance, but asking the client what are their goals and working with them collaboratively to reach what their goals are, rather than maybe your assumptions of their goals. So it's great to have a bit of a reflection moment here, and you're welcome to pop in the chat if you want to share. What model have you been practicing from consciously and unconsciously? Because we all have unconscious biases. Whether we want to or not, that's part of being human. And what model informs the environment and the systems that you work in, because you could be aligned with the neurodiversity affirming model, but then run up against a lot of systemic issues, especially if you work in a system like a hospital or a government employment service. That can make it really challenging to then be affirming. What model do you resonate with, and what trigger points have come up so far? So I'm just going to give people few seconds to reflect on that. Okay, so another thing that's important to really unpack when we're looking at becoming neurodiversity affirming is it really requires everyone to look at what implicit biases do we carry and do some self-reflection and some work on working to undo those, particularly when we are working with clients that face multiple barriers or multiple layers of implicit bias. So we know that things are more talked about, like sexism and racism. We still have quite a way to go on those, in fixing those. And then ageism often isn't talked about because of ageism. And there is a lot of ageism in autism and ADHD research and practice as well, in terms of a lot of the services and therapies and research is focused on autistic and ADHD children. And it's not really taking that developmental lifespan look, because, and this is the cynic in me, the analyst in me, wondering if that's because a lot of the therapies are for when people are children, trying to cure and fix them so they're no longer as autistic and ADHD when they're 18 and don't need as much support then. But we know from up-to-date research that actually autistic and ADHD people often do need ongoing support, and that, adult responsibilities and life gets harder when you're an adult. There are more demands on your time, and things like pregnancy and perimenopause and menopause, are times where people may need more support actually. But when we're looking, and I won't leave out homophobia and transphobia, and this is important to deconstruct if you're going to work with autism and ADHD, because research shows that there is a higher percentage of people who identify as trans, as queer, in autistic and ADHD populations. So there is a crossover there in the research. But one of the biggest things that often isn't talked about or addressed within our professions is ableism. So, the unconscious bias against disability and people with disabilities. And that's something that you really need to work on deconstructing when working with autism and ADHD and becoming neuroaffirming. So when we're talking about ableism, some of the common things that come up, and when we're looking at implicit bias, it often is unconscious, thoughts, behaviors, and social prejudices that unfortunately do lead to more stigma, more microaggressions, and more discrimination. And some of the common forms of ableism are assuming incompetence because someone has maybe told you that they're autistic and ADHD. So for using myself as an example, a lot of people said that they were surprised when I came out as autistic and ADHD on the podcast from the start, because of the risk to my career of people then assuming, how could I be a psychologist and also be autistic? Because there's stereotypes about autism and things like social communication skills. That's an example of, assuming incompetence. The belief that neurotypical abilities or interests or social norms and customs are superior to all others. So a lot of people are surprised when I tell them that autistic people have their own social norms and customs. It's never even occurred to them before. And that's actually ableism at play, for that to never even occur to you. And there's things like covert and overt ableism. So there's more obvious ableism, like not having maybe wheelchair access to your building or not having a toilet, in your clinic that is wheelchair accessible. But then there are more subtle forms as well. So maybe saying that, we want to hire more diversity of people, but then making all of the application processes and forms really inaccessible and not offering accommodations. So here's some more examples of ableism, and I hope that you go away from this bringing this up and talking about this with your colleagues and working through this, whether it's in peer consultation or supervision, in your own supervision, your own reflection. But things like with dyslexia, so the assumption that reading is a fundamental skill, and if you're not able to read the way the majority does or learn the way that the majority does, that you're not intelligent. So many people have been damaged by that stereotype and that form of ableism. With ADHD, our school systems assume that people learn best when sitting still. And we know that even for neurotypical kids, that can be challenging. With autism, a form of ableism is only valuing autistic people that have savant skills or special abilities, or those that are intellectually gifted. Assuming that spoken language is a superior form of communication and that everyone wants to use spoken language. Assuming that everyone should enjoy and value and do small talk because that's just the way it is. And assuming that eye contact is necessary or superior when communicating. And when we're looking at being truly neurodiversity affirming, it's really important to consume content and do training by people with lived experience, because it's part of being neurodiversity affirming and anti-ableist. And a lot of research has been done on autistic people in particular without consulting them. And a lot of assumptions have actually been made about autistic people because the researchers were mainly neurotypical. And so implicit bias wasn't addressed. So it's really important that we actually include the communities that you're studying. And when you're looking at educating yourself on autism and ADHD, that you do seek out lived experience voices, and look at whether autistic and ADHD people have been included or consulted on that research, that training, that book, that podcast, whatever it is. And that's going to help undo a lot of harm that's been done to these communities. So when we're looking at clinically, why has the interest in being neurodiversity affirming, kind of come to a head? And, why is it important that we all update our skills in this area, particularly in Australia? So in Australia, we've had an update to best practice guidelines with autism, with the Autism CRC. A new version got released in 2023. The previous version was in 2018. And the term neurodiversity affirming model is referenced 27 times in the new Autism CRC guidelines. And the new Autism CRC guidelines have recommendations in there backed by evidence and community consensus around things like not forcing eye contact for autistic children, and things like learning about their autistic identity is actually integral for their mental health. So again, things are progressing. We then had our first ever ADHD national guidelines in Australia. They only came out in 2022. They came out through ADPA. I would suggest if you're interested in ADHD and you're in Australia or New Zealand joining ADPA, they have lots of resources, and really amazing community there. But there are neurodiversity affirming principles in the best practice guidelines through ADPA, and they've all been endorsed by the MHCR. I can't remember the acronym right now. But yeah, they've been endorsed by all the professional bodies in Australia and the highest level of research review. And they are neurodiversity affirming in terms of identifying people with ADHD strengths and also bringing in appropriate environmental accommodations. And we know that there is more and more research coming out on neurodiversity affirming practice, and that doing neurodiversity affirming practice actually promotes self-determinism and well-being for neurodivergent people. We also have the National Autism Strategy, which will be released at the end of this year. I consulted on the National Autism Strategy as a lived experience and clinical member of the Diagnosis, Services and Supports Working Group. And yeah, this is going to be the new guide in Australia. So it's important to note with the National Autism Strategy that they are using a biopsychosocial model of disability and a strengths-based and neurodiversity affirming approach. So if you want your work to be in line with the national strategy and best practice, you do need to update your practice so that you're neurodiversity affirming. It's important to identify too that in this strategy, the government has used identity-first language, which is the preference of the autistic community in research. Not everyone prefers that language, but it is the majority preference. So autistic person versus person with autism. And they have four key outcome areas that they want to improve in. The first is social inclusion, which is getting more information out there about autism that reduces stereotyping and stigma. Economic inclusion, and in economic inclusion, they really want autistic people in education and the workforce in a way that is neurodiversity affirming. To improve access to diagnosis services and supports and improve the health and mental health of autistic people. So autistic people have been identified as a priority across all health services in Australia because of the shocking statistics with mental and physical health. They're quite dire. And yeah, basically one thing I wanted to note for autistic health and mental health professionals is that in the commitments, they are encouraging a greater representation of people with lived experience of being autistic in delivering supports and services to autistic people. So autistic health, mental health professionals and researchers are going to be supported by this strategy. We also have the updated competencies in Australia that are coming into effect at the end of next year. So people have a year now to update their practice. So all psychologists in Australia will have to update their practice and show that they have competency in understanding neurodiversity from a strength-based, trauma-informed and positive approach to supporting people with developmental disabilities. And they need to demonstrate competency in adapting psychological practice and making reasonable adjustments, including working with people who use AAC. Another competency is around working without discrimination, so working on being anti-ableist, being inclusive, sensitive, and respectful of all forms of individual diversity, not just in clients, but actually in our colleagues. And I think that's really important, and relevant others, and that includes disability. And then understanding with competency 7.2, the history and acknowledging the history of psychological theories and practice. So acknowledging the harm that's been done through the medical model and certain types of therapies and approaches to autistic people and ADHD people. And then also self-reflection, recognizing the impact of your own values, beliefs, experiences, your positions, and your cultural identity on your practice, and developing an ongoing commitment to culturally responsive practice. So yeah, it's really important, and this is an ongoing process. Doing this introduction webinar is wonderful, but it does take ongoing learning and self-reflection to be neurodiversity affirming. One webinar isn't it. So yeah, it really kind of requires deep work. So when we're looking at coming towards screening, I just want to talk quickly about some of the barriers that autistic and ADHD people face when it comes to being identified and what the cost of that is. So Previously, I believe working with autism and ADHD was seen as quite a niche. I know at least in psychology it was. And we get trained a little bit in like everything, so that we're competent, but it was kind of seen as something that you would only upskill in if you're going to work specifically in that area. Now, with updated research, we know that autistic and ADHD people who maybe haven't been diagnosed and recognized are overpopulated in our mental health services, in our drug and alcohol services, our eating disorder services, our prison and justice services, our homelessness services, our domestic violence services, and our private practice as well as the public system and private system. So yeah, whether you want to or not, you will be working with autistic and ADHD people. And a great example of this is there was a study that found that 22% of autistic women are hospitalized for a psychiatric issue by the time they turn 25, and that's 5 times higher than for autistic men and much higher than that for non-autistic, so neurotypical men and women. So within our hospitals and our private hospitals, autistic and ADHD women are far overrepresented, but maybe not diagnosed or screened. And so, yeah, it's really important because autistic and ADHD people are quite vulnerable to experiencing adverse events and outcomes without being properly identified. We know also that when people are identified, or if they aren't yet, they're often brought to services because their behaviours are seen as a problem by other people. Many people have tried lots of different types of therapies if they don't know that they're autistic or ADHD, have tried many different medications, psychologists, therapists, psychiatrists, and yeah, I feel like nothing has seemed to work or they haven't quite found the right answer. And yeah, unfortunately, people can have very negative experiences before diagnosis and even after diagnosis when disclosing that they have been diagnosed as autistic or ADHD due to stereotypes and lack of knowledge about autism and ADHD in mental health. So yeah, people often find that they are dismissed or invalidated, particularly if you're an autistic woman or assigned female at birth. So yeah, like I myself, after I was diagnosed, so my husband went and saw a psychiatrist and, you know, we get along and everything's great. But in the first session, I disclosed that I was autistic because I thought it was relevant for him to know. And the psychiatrist point blank said, no, you can't possibly be autistic. And I was like, well, you're not my psychiatrist and you don't even know me. Like, how can you tell? Like, why would you say that? And there was a long pause and he couldn't really give an answer. And I think it's due to stereotypes. So even I can get invalidated and dismissed with all the public profile that I have. So yeah, it's a lot worse for people, unfortunately. And that makes people not want to seek out services then, unfortunately. We also know that autistic and ADHD people can often have a lot of burnout when interacting with so many different systems and needing lots of different types of support. And not every part of the system is aligned with neurodiversity-affirming care. And yeah, that can be really tough. And yeah, often you can experience a lot of negative feedback that can impact your mental health. So, for example, smile more, look people in the eyes, that's rude, you're disorganized, you're lazy. So, yeah, it's really tough out there for autistic and ADHD people. And the people that in particular get missed for screening and then referral for diagnosis or even get missed in formal assessments are often autistic and ADHD women and those assigned female at birth, and particularly those with strong verbal abilities. And unfortunately, people are often misdiagnosed with depression or generalized anxiety or other things. The other people that are not picked up well by a lot of previous screeners and assessment processes are people who are intellectually gifted, who are twice exceptional, so who are both autistic or ADHD and have above average intelligence or a gifted level of intelligence, because with your cognitive abilities, you're able to compensate until a certain point, and then things collapse. People who are high masking and internalizing, and this can be men and women, and again, non-binary people as well, and trans people. And then also people who have a dual neurotype. So people who are autistic and ADHD. Before 2013, we actually weren't allowed to diagnose people with both. You could only diagnose one or the other. And that was because in America, there was a concern with people being diagnosed with ADHD and not autism. But now since 2013, we actually know through up-to-date research that it's really common for people to be both neurotypes, to have a dual neurodivergence. And a lot of our screening tools and measures were created before 2013, like, for example, the ADOS, and they haven't been updated to take this into consideration. And a lot of research hasn't taken this into consideration as well, that people may present differently, or because they're both, they may not meet the threshold on a screener because their ADHD is compensating for their autism and vice versa. We also have people who are First Nations people or from an immigrant background, maybe English isn't their first language, people from the LGBTQIA plus community, people who are rural and in regional areas and have less access to services and information, people from a low socioeconomic background because it's very expensive, because there's not a lot of public services once you become an adult that support autism and ADHD. And then there's a whole generation of older people, so, 40, 50 plus, 60 plus, who missed out on getting a diagnosis because of stereotypes about autism and ADHD when they were young and in school. So unfortunately, people can get misdiagnosed. Burnout can seem like depression. People may get identified with co-occurring things like a substance use disorder or an eating disorder, but autism or ADHD, a neurodevelopmental difference, is not actually then identified maybe as the underlying factor for the risk of developing those coping strategies. Unfortunately, it's quite common, or was in the past, hopefully, for autistic and ADHD women and AFAB to get diagnosed with borderline personality disorder instead of being properly screened for, are they autistic or ADHD? And we know that autistic and ADHD people do have higher risk for developing mental health conditions, as well as being, neurologically different, having co-occurring mental health conditions like anxiety, like PTSD, anorexia, schizophrenia, OCD, bipolar. And one of the ones that isn't as talked about is premenstrual dysphoric disorder as well, is much more common in autistic and ADHD women and AFAB. We know that getting a late diagnosis is more common in women. And when we have a look at this large study from 2022 from the US, they were looking at what's the difference between people who got diagnosed as autistic when they were kids and the people that received a late diagnosis in adulthood. They found that the people that got a delayed diagnosis were actually more likely to have more psychiatric and mental health issues and have more lifetime psychiatric diagnoses, even after controlling for age at reporting, intellectual disability, and sex at birth. So not getting an early diagnosis looks like it's pretty poor for people's mental health because they don't get the support. They don't understand why they're struggling, why they're different, why they're getting bullied. And other people around them don't understand either. The people who were diagnosed as adults were less likely to report some of the typical things that you might think of with autism. So things like delayed developmental milestones, speech or language delays, learning difficulties, motor delays. Instead, they were more likely to, and particularly for women, report mutism, sleep issues, mood, anxiety, and eating disorders. So there seems to be a different profile. People who don't, display classic developmental differences when they're children, then don't get flagged for assessment and then miss out on support. So I just think that's a really interesting study looking at that difference between early diagnosis and late diagnosis and what's the impact and why. So we know that when people are late diagnosed, they lose opportunities like education and employment opportunities, in terms of, yeah, not having any accommodations, burning out, and not getting support. People may have poor therapeutic and health experiences when trying to engage with those systems. It impacts the formation of your identity if you're late diagnosed. You are more likely to reach autistic burnout. And people develop self-blame and low self-worth issues with late diagnosis. There's also more risk of social isolation, disengagement, and accumulated stress. And a lot of people who are late diagnosed and don't know that they're autistic, but they know that they're different, will often try to mask their differences as a survival strategy. And in recent research, we've learned that unfortunately, masking is strongly associated with worse mental health, poorer well-being, increased depression, and higher rates of suicidal thoughts and behaviors. And it really brings into question some of the therapies, that in the past have been around teaching people how to mask their autism, to appear non-autistic, to socialize in a neurotypical way. And now this research is showing that, yeah, that may not be great for people's mental health. And it makes them really tired and fatigued. So, yeah, it's bringing up a lot of questions, I suppose. We also know that ADHD is underdiagnosed. So if you look at the ADPA guidelines, they state that ADHD in general is underdiagnosed. It's not actually overdiagnosed. And for women in particular and girls, it's underdiagnosed even more. And it's undertreated as well. And unfortunately, ADHD can be misdiagnosed sometimes as anxiety or depression or personality disorders or bipolar. And this can often be with women and AFAB. They may present differently, or they may have a more internalized presentation that's more inattentive. But I've also met and assessed many or ADHD men that got a late diagnosis, like my brother and my husband, because they were more inattentive, and they didn't meet that stereotype of the typical ADHD boy. And I've met lots of girls and women in AFAB who clearly had combined ADHD, and, the hyperactive impulsive element wasn't diagnosed, because gender norms weren't taken into account. There's other things to consider too when you're looking at potentially screening a client and you're questioning, are they potentially neurodivergent? So for girls and women and AFAB, they are more likely to use compensatory strategies. So having multiple diaries and calendars and alarms set to keep on track, checking things like 10 times before sending it off because, they're afraid that they've made a careless mistake. And they may not realize that that's actually not typical, and that other people who are neurotypical don't need to do those things to remember basic tasks. So yeah, it's making sure that you're taking that into account. And also, if someone is achieving academically or getting good grades, not dismissing potential ADHD because of that. And again, that's because of an ableist assumption that you can only have ADHD if you're quote unquote stupid or don't do well at school. So it's really deconstructing these assumptions and stereotypes. And unfortunately, there have been lots of women that have been told that they can't possibly be ADHD because they have a degree and they managed to finish a uni degree because they're married and have children, which I'm not really sure what that has to do with it. But again, that's just an example of the many different microaggressions and yeah, stereotyping, sexism that is present in autism and ADHD. So what is the cost of not getting an ADHD diagnosis? Well, it's actually pretty high. So the cost of ADHD that's not identified, treated with medication and supported, it can actually reduce your lifespan up to 20 years. And that's mainly due to accidental death and injuries through hyperactivity or impulsivity or inattention. Driving incidences as well. And there's also higher risks of things like developing anxiety and depression, eating disorders, substance use disorders, developing hoarding, skin picking and hair pulling, and relationship issues, as well as breaking the law and contact with the justice system and self-harm and suicide. So the costs are pretty bad. So unfortunately, there is a lot of bias in terms of cost, ageism, a lot of the original diagnostic criteria. When we actually look at, for example, the ADOS, the original sample that the ADOS was based on was an 80% white male child sample. And so it wasn't really representative in terms of picking up people who are not white and male and children. And when we're looking at the diagnostic criteria for both autism and ADHD, they do carry those biases in them as well. So people often have questions about the prevalence rate and why has the prevalence rate of autism and ADHD increased? And actually, Australia's prevalence rate has increased, but it's increased to what is in line with other countries like Japan and the UK. And the reason why the prevalence rate has increased is due to the people that were not getting picked up or diagnosed because of bias in the diagnostic criteria are now starting to get picked up and diagnosed. So when you're only picking up a small percentage of that clinical population, yeah, it's probably going to be an underestimate of the actual prevalence. Okay. Same with ADHD. So it's interesting when we look at the ageism bias, because again, one of the stereotypes and myths about ADHD is that you grow out of it. I can assure you that you absolutely do not. And if you're a woman or assigned female at birth, it actually gets a lot harder to manage when you hit perimenopause. So yeah, you definitely don't grow out of it. But yeah, you can see the ageism bias in that the prevalence rate in children is 7.2%, and it's a neurodevelopmental condition. It's not a mental health condition. It's not a behavioral disorder. And those are how it's previously been characterized. Yet the adult prevalence is only 2.8%. So there's a bit of a bias there where I think the adult rate is actually under represented. Okay, so when we're looking at choosing assessment tools as well, we really want to look at the stereotypes and myths that might prevent you from screening someone and seeking out research, more up-to-date research. If you're relying on what you were taught at uni, that's probably out of date now when it comes to autism and ADHD, unless it's referencing things within the last 5 years, because autism and ADHD research is like, there's just so much new stuff coming out, and it means that a lot of the old stuff is outdated. Okay, so I'm just gonna skip through this. This is again one of the biases with autism. So when we have a look at we've talked about the medical model, which is often aimed at fixing or curing autism and looks at interventions to change autistic like social behaviors and make them more neurotypical. And the social model of disability, which is more about understanding, supporting, accommodating, not trying to change who you are, and recognizing the costs of some of these other models. When we look at where funding is allocated with autism, we can see that 50% of the funding in Australia from 2013 to 2017 was focused on finding the genes for autism so that it can be cured. 20% was other. Another 20% was focused on treatments that were reducing autistic symptoms, and only 10% of funding around autism was focused on actually supporting autistic people in their life and what they want to achieve and having good quality of life. So that's pretty poor, and I think it's a great example of where the medical model prioritizes things sometimes. So when we're looking at viewing autism through a more affirming lens, it's actually understanding that autism isn't a linear concept. You're not a little bit autistic or everyone's a little bit autistic. Actually, you're either autistic or you're not. Autistic people have a completely different social approach. We have an interest-based nervous system. We want to communicate, socialize, and base our life around our intense interests. And we use, other things like our sensory system and repetition and routines to regulate ourselves as well as stimming. And so, yeah, it's really important to understand, reconceptualize how you think about autism. When we're looking at ADHD, it's not really a disorder of executive functioning. It's a different distribution of executive functioning resources. And it's actually a difference in regulation. So a lot of ADHDers will find that the focus really is on their behavior when actually it's hard regulating your thoughts. It's harder to regulate your emotions. And then there's the executive functioning regulation as well. So again, there's, I think, some myths and stereotypes about that. When we're looking at becoming affirming, we really want to identify what the strengths of each neurotype are, because there are strengths, and look at how we can encourage clients to identify those and lean into them. So for autism, being honest, having integrity, wanting to follow rules, liking to know what your facts are so that you can back yourself up, preferring routine and disliking uncertainty, having logical thinking and attention to detail, being more direct and honest, having detailed information about your area of interest. So there's lots of different strengths that autistic people bring to the table that education and employment could make use of. When we're looking at ADHD strengths, one of them is hyperfocus. So getting a lot done in like an intense focus period and really being able to excel in what your interests are, being creative, innovative, out of the box thinking, novel solutions, having high energy. If you're lucky and you're hyperactive, the more the hyperactive type, being more open to spontaneity, rolling with change, and loving a broad range of different interests and information. So I know we're kind of coming to a little bit of time here, so I'm going to do my best to whip through this. So coming now more to when to screen. So like I said, if you have a client that has a long history of getting lots of different diagnoses, trying lots of different treatments, therapies, medications, but nothing really seems to work, you should probably look at, is this actually mental health, or is there a neurodevelopmental difference here that needs identifying and supporting? And that's the reason why the person has all of these mental health challenges. Is there a family history of neurodivergence? So has their brother or their parent or their child just been diagnosed? Because it is mainly genetic, like autism is up to 90% heritable. ADHD is 70 to 90% heritable. So yeah, it runs in families. Having a look at, addressing stereotypes, have you maybe not considered neurodivergence because of stereotypes about what autism and ADHD should look like, and the client doesn't fit that? So consider screening. And how I bring it up with clients is from the start, I'll say, look, it's really important for me to, as part of this intake assessment, to do a bit of a screening to see if you are neurodivergent, because if you're neurodivergent, how, we would work with you would be a little bit different in terms of what works than if you are neurotypical. And so it's really helpful for me to know if you're neurotypical or neurodivergent to tailor the therapy to you and make sure you're getting what you need to make the most of this and get the best outcomes. So do the screening, have a look at the results, debrief. If the person's high on the screening, then do some neurodiversity-affirming psychoeducation about their neurotype. And if you aren't confident in assessing, then refer them to someone that specializes in neurodiversity-affirming assessments. And yeah, give the client information about like assessment and what the referral pathway is and what would it mean to go for an assessment and get a diagnosis. Some of the things that you should be looking for in clients who are potentially autistic are long-term history of difficulty making and keeping friends in a neurotypical way and interpersonal challenges, history of them having social anxiety and saying, but it's more around, I don't really know what to say or why people are saying or doing these things. I don't know what the rules are. rather than perhaps it being solely focused around being judged by other people. Having situational mutism when stressed, and experiences of bullying and social trauma, needing to drink to go to social events, to be able to engage socially is another bit of a clue. People having differences in their facial affect and eye contact, and maybe the content of what they talk about in sessions as well. If they have a really intense interest that they love to talk about and they light up around. Disclosing sensory sensitivities, and you should be asking about these if you are going, is this neurodivergence or is it mental health? Does the person stim? You should see that in session, or ask them about it. Having perfectionism, as well as the need for routine and difficulty with change and uncertainty. A bit of a history of finding full-time work, university, and school challenging, and periods of burnout ongoing. Finding that maybe their autism gets unmasked at different periods of their life where there's a lot going on and a lot of change. So after leaving school and trying to go to uni, after having children, going through perimenopause, changing roles at work, moving house, emotional dysregulation, the client reporting that they feel like an alien, feeling different to everyone always. And in session, you might note that they take instructions literally or need more clarification. They might ask more questions and ask why. They may not understand vague explanations. You may need to sit with them when they go through and do screeners, where you don't need to do that with other clients who seem to instinctively know what the screener actually means and what's being asked. And we're looking for, history of substance use, eating disorders, some of those co-occurring conditions, as well as difficulty with tasks of daily living, like self-care, hygiene, and cooking. Well, also for ADHD, you should be considering if the client has a history of daydreaming. Are they inattentive and easily distracted? You should see that in session. If they describe things like they're having so many thoughts all at once, like having being ADHD is literally like having 6 different streams of thoughts at once, and as well as like Elton John music playing in the background and like a gif of a hamster, and it's like a very busy place to be, which can then feel like anxiety or be misdiagnosed as anxiety. Forgetfulness, so do they leave their wallet or their phone or their purse behind? Do they forget the appointments booked in and don't show? Do they forget what you said last session and I can't remember, or what their therapy homework was? Do they talk quickly and tangentially as well? Is there a history of impulsivity? So lots of different areas that aren't asked about are spending, hyperimpulsivity with sex, having debts, binge eating, exercising, cannabis, alcohol, speeding, difficulty starting and finishing things. It's a lot more effortful for them, and they just can't get it done. And having a spiky profile on grades, so doing really well at the subjects that they're interested in and bottoming out on everything else. And with ADHD, we may see decompensation when people hit a certain point where their cognitive ability can no longer buffer them. And for a lot of people with above average IQ, it's high school, grade 10, 11, and 12. Suddenly they fall flat, or it might be university for some people. Having a history of multiple different jobs, hobbies, interests, starting lots of courses or degrees, but finding it really hard to maintain interest and finish. And using lots of different diaries, calendars, not being able to sit and just pay attention to one thing unless you're really interested in it. But like if they were to sit down and watch a movie, they can't. So getting up, moving around, having to scroll on your phone and do something else at the same time due to needing lots of stimulation and constantly being bored. Having hoarding and clutter and disorganization, and a lot of difficulty with self-care tasks as well. So when we're looking at who can assess autism in Australia, the Autism CRC has guidelines. With people under 18, it needs to be 2 clinicians that are in consensus, So, for example, a psychologist and a speech pathologist. For adults, it can be a sole clinician, such as a psychologist or a psychiatrist, but it needs to be by a lead practitioner. So if we have down there, those are the different professions in Australia and the lead practitioners. Okay. When we're looking at autism assessment, the gold standard actually is the clinical expertise and experience that the clinician has and whether they've kept up to date with their practice. A single tool or assessment tool in itself is not actually the gold standard because whether it will be suitable for each individual person is going to differ with the person. So for example, with the ADOS is a practical-based, activity-based autism assessment that may be used with children, but I would argue that for using it with adults, it's probably inappropriate and it's not affirming because there's an emphasis on things like literal thinking and theory of mind, which are quite outdated and would only capture a certain proportion of autistic people. It wouldn't capture people that don't think literally but are autistic or have a vivid imagination and are very creative and are autistic. In addition, with the ADOS, it can be this could sound a bit harsh, but I don't think it's respectful. And I don't think it's affirming because part of the ADOS is that the tasks are designed to be hard and really uncomfortable for an autistic person to do, and you're deliberately provoking distress in the autistic person so that they then show you that they can't do the task and they're distressed and get agitated by it. And yeah, I think when we're looking at ableism and updating our practice, is that actually ethical? I would say. Is it necessary? Are there better tools out there? And if there aren't, why don't we have them? The MIGDAS is a structured qualitative interview, and that has pros and strengths and cons as well. There'll be some people where a MIGDAS may not be suitable or affirming for them because the language demands and even things like using AAC might be really fatiguing for that person or draining for that person. So it's really important that you actually assess the individual and think about an assessment plan that is respectful and affirming for that individual and meets that individual's needs. You also would need to gather collateral information from childhood right through to where they are now. And you're looking at gathering a developmental history and doing a full differential diagnosis process. And unfortunately, a lot of the assessments, like I said, were constructed before 2013 and don't capture like our evolving understanding of autism and what it looks like in women and AFAB, what it looks like in people who aren't white, and what it looks like in people with a dual neurotype of being ADHD. And yeah, like what Ben said, doing an assessment is actually a therapeutic process. Going through the assessment process with the person and the feedback and the report, you need to ask yourself and reflect on this. Is your assessment process respectful? Is it appropriate? If it's deliberately eliciting distress, is that okay? Are you okay with that? When I did the ADOS training as an autistic person and I had to do the task, it made me feel really uncomfortable. And I just was like, this is really actually mean. I don't like this. This is me being honest as an autistic person. And do I want to put another autistic person through that, knowing what it feels like, whether they're a child or an adult? Is your assessment process collaborative? I explain the two different assessments and my reasoning and ask people what they would prefer and take that into account. Be collaborative. Is it trauma informed? And is it affirming? Do your clients leave the assessment session feeling empowered and knowledgeable about their neurotype? Do they leave the feedback feeling like that was a positive and empowering experience? Do they feel listened to and respected? So we have some screeners, and I know I'm going a little bit over time here. I'm so sorry. I really do have trouble keeping to time with ADHD. So I'm just going to try and quickly finish up. But we have screeners here. I would recommend the Caddy. Like Ben said, it's updated. It actually has an autistic researcher on the team that's created it. It has up-to-date norms for different genders, different ages. So it really addresses some of those implicit biases. The RADS are is okay. It's us before the age of 16 and what we were like after the age of 16. So it does take into account some learned masked behaviors. The AQ isn't great for women in AFAB. I'll say that. It doesn't tend to pick them up very well, and it really needs rewording, and for the norms to kind of be reviewed. If you have a client that you think is masking, get them to do the CAT-Q because it's great at discriminating. Is the person neurotypical or ADHD only, or are they autistic or autistic and ADHD? And then another one that I would link in is the Maya too. So looking at the person's interoception. So a lot of autistic people, not all, but a lot have interoception differences and difficulties that are not asked about by clinicians. And if the client doesn't have great interoception, and then you're going and doing a higher level therapy around mindfulness and emotions and stuff like that, you really need to have built that building block, working on interoception first and assessing that first. So there's some more tips there, but I'm going to move on. And with ADHD, have a look at the ADPA guidelines. People who can diagnose ADHD are pediatricians, psychiatrists, and psychologists in Australia. Other allied health, such as GPs and allied health, can use the screening tools. The number one screening tool I would recommend is the ASRS. It's very quick. It's freely available. It has a good discrimination, and it usually is a pretty good indicator if someone scores above threshold in Part A, if you should look into ADHD further for that person. And yeah, there's certain populations that ADPA recommends you should screen ADHD in and take into account. So kids that are in out-of-home care, kids that are diagnosed with oppositional defiant disorder and conduct disorder, people with anxiety and epilepsy, and for teens, those with substance use disorders, anxiety and epilepsy, and for adults, those who are autistic, have an intellectual disability, a learning disability, an acquired brain injury, a family history of ADHD, preterm birth or low birth weight should be screened for ADHD. ADPA also notes that cognitive testing, neuropsychological testing within itself is not necessary for an ADHD diagnosis. It may be used for assessing IQ, learning disorders, or learning about the person's cognitive profile. But yeah, it shouldn't really be in itself being used to assess for ADHD. So my husband, I've just boasted about him for a bit, but he fell in the 99th percentile across all of the domains. And so a cognitive test alone wouldn't have shown that he has ADHD. So like I said, the ASRS is great. And then Ben mentioned the Executive Skills Questionnaire Revise. And that's great if you want to learn more and the client wants to learn more about their executive functioning strengths and challenges. And then you can look at what to address in therapy. And for the client self-knowledge, it's awesome. So I definitely recommend that. And then, yeah, if you want more training on neurodiversity-affirming therapy, I have a model that we train at with Divergent Futures called the Square Model. It's really a thorough training. We have that coming up in March next year. And the first 15 people to sign up get a significant discount. So yeah, if you're interested in furthering your practice, you can also follow us and join our emailing list. And I have included some people who do training specifically on neurodiversity affirming assessment if you want further training in that as well. So I'm so sorry I ran over everyone.
Oh, that's okay. I think I think everyone's really
Inevitable.
interested in it, and I know that you wanted me to be monitoring the chat with all of the
Yeah,
discussions because multitasking for anyone
it's
is
hard.
hard, especially when you're doing a webinar.
Yes,
And the
thank
chat was going
you.
absolutely wild, heaps of people. I want to give you a
Oh,
few
amazing.
questions.
Yep, great.
Um,
Let's do it.
Lots of people saying if I want to do more training about these approaches and with you in particular, I think you're very popular. Where do they go?
Yeah, so you Google Divergent Futures, my training company, and we have a comprehensive training in March next year. Day one is really going in depth about some of the more of the things that we've covered today and neurodiversity affirming practice. And part two covers the square model, which is something that I came up, which really conceptualizes what are the neurodivergent needs in therapy. So whether the person's autistic or ADHD, it really thoroughly covers sensory needs and differences, interoception and how to work with that as a therapist and as a psychologist, and how to assess that, executive functioning and all of the tips and tools for working with that and helping the person understand themselves. We cover burnout, we cover trauma. Yeah, so it's super comprehensive. Yeah.
So I've selected a few of the questions. So a theme was how is the neuroaffirming approach different from a strengths-based approach, or are they sort of the same thing just with a different name?
Yeah, they're the same thing. Yeah, I guess like when we're looking at psychology, there are some therapies that are more strengths-based, like intuitively, and then there are more like some therapies that maybe focus more on what do we want to fix here? You know what I mean? What are the deficits, the skills that we need to build? But yeah, it's really bringing that strength-based approach and applying it to autism and ADHD because, to be honest, up until probably the last 10, 20 years, despite the hard work of a lot of autistic and ADHD advocates and parents, strengths haven't really been applied specifically to autism and ADHD. It really has been about this child's not making eye contact. How can we make them, fit in more and not get bullied, by making more eye contact, things like that. So even though it seems simple, it's actually really new when applied to this area, unfortunately.
Yeah. Question here, someone asks, are we at risk of diagnosing people and women in particular who camouflage um, over diagnosing autism just because they're camouflaging, and women in particular?
Well, honestly, probably not. Like I do autism and ADHD adult assessments, and the majority of people who have presented for assessment over the past 3 years have been women. And so I think there's an overrepresentation of women in AFAB presenting for assessment because they've been underdiagnosed for so long.
Yeah.
And if you use the tools and if you have a really good understanding of autism and ADHD and how it manifests like in different people and like the diversity within autism and ADHD. And you understand the key principles of what makes someone autistic, what makes someone ADHD versus neurotypical, you're able to kind of work through the implicit bias in the screeners.
And
Yeah.
question here, what are the extra considerations with people who are gender diverse and also mentioning the CATI, the Comprehensive Autistic Trait Inventory, does that do a better job compared to the AQ?
Yes, it does. Yeah.
I mean, I think that the CATI, I mean, it's such a, I think it's an amazing measure. Um, uh, it's an Australian measure. It's got norms for men, women, gender diverse,
Yep.
gen, it's just all of those problems with the AQ over the years. I think it's like
Yeah.
pretty much nailed all of them and fixed them all. So I reckon it's the best out there at the moment.
It is my preference over the AQ for sure. Mm.
Yeah. So I think we're gonna finish up there. And also I'd just like to do let everyone know that there is a upcoming webinar. The next webinar that we have is on AI note taking, and that's in only 50 days. So if you go to the NovoPsych website, go to training, and then click on this one, you will be able to register there. Um, Monique, thank you so much for um, presenting an absolutely wonderful, very informative webinar tonight. I love the contrast between the classical sort of training, which I was trained in, then the new way of thinking, which is really quite new and quite different, but so much better for clients.
Yes.
And so thank you very much. And for all the participants tonight, thank you for attending. Your enthusiasm for these free webinars that NovoPsych put on helps us keep motivated to continue doing them. And I want to just shout out all the clinicians that do a wonderful job every day in their practice, but are taking time out on nights like tonight to do even better. So well done, everyone. And Monique Mitchelson, thank you so much. Bye.
Yay. Thank you, everyone. Thanks for coming.